Welcome back to the channel. It's my honor and pleasure to introduce my dear friend and colleague, Dr. Nampalli Vijay. This is a gentleman who is famous in Denver and has treated thousands of patients over his career of almost 55 years as a partner at Aurora Denver Cardiology and an instructor at the University of Colorado. He's published numerous articles on clinical research, and he has also been a partner with many of us. I can tell you from my own experience, he's one of the finest physicians you'll ever meet. And when you are a heart surgeon, you depend on the rigors of the cardiologist presenting patients to you. And I can tell you, every patient he ever presented to me was perfect for the therapy which he stated, and the outcomes were superb as a result of that. But more than that, I respect his abilities very much. The interesting thing about him is he came from India originally, and he's now practiced medicine for 55 years. And he grew up in Hyderabad. He was educated there, and then he did his cardiac fellowship or cardiology fellowship in Denver. And then beyond that, practiced in Denver for his whole career. And I am completely elated to have him on the channel today. Welcome, Dr. Nampalli Vijay. Thank you so much for...
Good morning, Ram. Good to be on the channel today.
I spoke about this on a chat on Scroll a few weeks ago, that heart disease is clearly the #1 killer of not only Americans, but globally. And yet you're faced with a situation where for non-elective patients, many of those patients were scared to come in. And further, if the beds were not available in ICUs, you couldn't potentially take care of them. Did you face that in March and onwards? Did you see a drop in the number of visits coming to your clinic or going to the cath labs?
Yes, that has been the case. In our practice, the number of patients who are coming in with acute MI or acute ACS has steadily gone down. And I think there is a drop of about 40% in the admissions for acute coronary syndrome cases in the last 8 or 9 months that we have had this COVID raging through the country.
So now, heart disease is always about supply and demand. And one would say that if they're not going out and exerting themselves, potentially they may not have as many events. But, realistically, I would say some of your chronic patients who you've been nursing along may not get the care they need. Are you seeing this in sudden cardiac deaths increasing, or we don't really know because they come in and no one really does autopsies or no one really figures it out? What is your opinion there?
Because of the COVID going on, I think the incidence of death cannot be assessed accurately, whether it's related to underlying cardiac disease or secondary to COVID illness, because some of these people are dying due to massive pneumonia and before they get to the hospital. And some of the patients are dying as a result of cardiogenic shock because of the inflammatory response and the cytokine storm that occurs in some of these patients. So they don't even get to the hospital, so we don't know what happens to them.
So that brings me to another question, that how susceptible are your patients who have existing comorbidities with heart disease, hypertension, maybe some chronic renal insufficiency or kidney disease, and some lung disease to COVID? I mean, I would imagine, all the data suggests that it's much higher for morbidity, meaning them getting hospitalized and having side effects or complications, as well as potential death. Is that true? Is that what you're seeing?
Yeah, that is absolutely true. And I think what has happened is the largest study that was done initially from right around January 1st of this year to March end of this year was in Wuhan, China, where they had the largest number of cases that occurred and the earliest cases that occurred in China. That's where we started off. Therefore, most of our knowledge is based on the work done in China. And this has shown clearly that the incidence of diabetes is a bad prognosticator. The incidence of underlying coronary heart disease is a bad prognosticator. And the incidence of hypertension is bad for survival because of the risks involved and the mortality rates that have been described. Therefore, I think we have been warning our patients to avoid the usual contact with the people in the hospital and try not to gather in groups of more than the immediate family and not to travel. That's what we have been advising them. And so the telemedicine has taken off like never before. And even though it's of limited value, and especially in people who are coming in for the first time, I would hate to make a diagnosis based on telemedicine, but it is added a dimension to our knowledge and care of these patients.
So two points came out with what you said. The first is, with all of these comorbidities, a patient who's having chest pain, chest pressure, shortness of breath, or typical or atypical symptoms needs to be evaluated in spite of the fact that they have to come to the hospital, because what we found in our search was that more people died of the heart disease than would have died of the COVID in any given year, certainly. And as long as you take the right measures, meaning masks and hand washing and calling ahead and sequencing, that works. The second thing is something you said about telemedicine and its role in the overall evaluation. And I think as a triage tool, it can be used effectively in some cases, but it doesn't replace the doctor-patient interaction, which you would see in the office. And that's an interesting point. There's a lot of people who don't have people like us available, particularly in India, where many of the people, don't have access to infrastructure, meaning hospitals or clinics or doctors. How would you overcome that, and what would you say would be the best approach?
I think if it is the first visit, especially if the patient is having chest pain, I usually insist that the patient come back to the office to be seen immediately as soon as possible, or get to the emergency room and I call up the emergency room and tell them that there is a patient who has got what looks like ACS, and he should acute coronary syndrome, and he should be seen as quickly as possible. That's number one. Number two is that when we do the testing, we can usually discuss the results by telemedicine through the telephone or through a video conferencing. We can talk to them because most people do have access to blood pressure recordings at home and weighing scales at home, and they can take their own pulse, and they also have pulse oximetry, which most people have bought as a result of the COVID infection, because they know that is one of the parameters is the oxygen desaturation that occurs that lets you make a decision whether you need to go to the hospital or not. So that is the reason why they all have a pulse oximetry. And we can get an idea by the pulse oximetry and the weight and the blood pressure if the patient needs to be seen again within the next couple of days or 3 days.
Perfect.
And that's what I do.
Tell me where you see heart disease going in the future. What do you see?
I think the biggest advance that has occurred in the preventive cardiology field, along with the acute interventions and the care of the patient, the preventive cardiology has assumed a major role. And now I think our aim is to keep the low density cholesterol as low as possible. And the new drugs that have come in are the PCSK9 inhibitors, which have reduced the cholesterol level to ridiculously low levels. With some of the LDL patients that I have who are on combination of statin and the PCSK9 have had cholesterols as low as 3 or 0 in some cases. And so it has not had any impact on the incidence of cancer of the gallbladder or cancer of the liver or anything like that. At the same time, has reduced the incidence. And a case in example is a patient of mine who continually had stent after stent done every year, and his cholesterol was not at goal. His LDL was high enough, which was more than 90, and we couldn't get it down to 70 in spite of the largest dose of a statin that we use. And we were able to put him on PCSK9, and he has had no more stents done in the last 3 years that I have followed him up. So that, I think, is a major advance that has occurred. The LDL focus has changed the paradigm to a certain extent, and has also brought in new cholesterol agents like atorvastatin and rosuvastatin or Crestor or Lipitor that we use in our practice now, and the use of high dose statins when a patient presents with acute coronary syndromes. So I think this has been a major advance that has occurred, plus the treatment of hypertension, obesity, a regular exercise program, and a diet low in fats and low in cholesterol has added to our knowledge of preventive cardiology to the point where we don't really have the same incidence as we had in 1972 when I started my fellowship or in the years that followed.
And so, just so we're clear, I think the rules of the game have changed to some degree in that primary prevention is no longer the, if I'm not mistaken, you're the expert on this, but primary prevention in LDLs and cholesterol is no longer the focus. These patients you've talked about have already had events, or they have a very high risk of having events. So, that for me was a huge change because, initially we were all trying to drop everyone's cholesterol and all their LDLs really low. Then when the studies came out, it did not suggest that was beneficial. But in patients who actually have evidence of heart disease, have had an MI, or have a strong family history of heart disease, it makes sense to use those techniques. Now, there's one other thing to talk about, and this is always a controversial one, but that's even evolved. When to use intervention in the way of stents, and then further, what are the current indications for bypass surgery in your mind?
I think, the bypass surgery has been shown to be beneficial in the left main stem disease or multivessel disease, especially in diabetics. There's no doubt that that is the major role for bypass surgery. And in those patients with multivessel disease or those patients with left main stem disease, where it's possible that the risks of surgery are much higher than the risks of doing an angioplasty, that we could still do a PCI and put a stent in each one of the arteries in a staged procedure if necessary, or just putting it for the left main stem and then protecting the LAD and the distal circumflex beyond the obstruction. I think that is the main consideration there. I think how much is the risk involved. Now, as far as
you wouldn't do that for a surgical candidate as your first line of attack, unless there was some mitigating circumstance where they weren't a surgical candidate and it was a salvage, correct?
Yeah, that's right. Yeah, I think if he's not a surgical candidate because of the high risk, STS score being very high, then you'd avoid doing a surgery on that patient with even with left main and go with percutaneous procedures. However, there is clear proof that long-term benefits are better in diabetics with surgery compared to PCI. And I think that has been my experience as well, that diabetics are better served with surgery than non-diabetics. But I think in non-diabetics, there is no such thing as not being able to perform a percutaneous procedure. It is possible to do that. And if you go to places like Scripps Clinic, they think that anybody can be done. So I think that's an extreme. But on the other hand, I think we have to use your judgment, and you have to use your common sense and making a decision in favor of the best treatment available for the patient.
Now, there was an interesting paper recently which talked about the indications for any type of intervention. And what they said is that for people without acute coronary syndrome, with just exertional angina, that medical therapy was actually better long-term and resulted in fewer complications than intervening. And that intervention, when I talk about that, it's stents or heart surgery. And that when they looked at both, that the medical therapy was as good in the terms of mortality or morbidity or better. What's your take on
that? I think, they went a little too far in that study, which we are talking about the Crusade and the other two trials that occurred. And they went a little bit too far. And I think they went to the extent of saying that medical treatment is all that they need, which is probably most people do not agree with that, and I do not agree with that. And I think each case has to be decided on an individual basis, keeping in mind all the other risks that are involved in that, and make a decision between a PCI and medical treatment in those cases. However, if the disease process is less than 65% without a FFR or fractional flow reserve, it is not indicated to do a PCI in those arteries with that kind of obstruction.
So this is a very interesting observation. And, until then, I don't think anyone was really measuring all of that. They were just eyeballing it and saying, this looks high grade, we ought to intervene because the patient has exertional angina or whatnot. And to be honest with you, I mean, things are evolving very quickly. And what do you think about genetic treatment with the new strategies, both for patients with, genetic apolipoprotein diseases, as well as patients who've had massive heart attacks and need stem cells and things like that? Do you think that is foreseeable in the future? And do you think that's something which will get better?
I think as time goes by, as more clinical trials are conducted, we are doing a trial called Aegis trial, where you give apolipoprotein 1 infusions at weekly intervals on some of these patients who have undergone an acute MI and have been stented or have had treatment for that, starting with the first infusion in the hospital and continuing that for 5 infusions, on the hope that this will prevent the recurrence of an MI. That is one of the hopes, and we don't have the results from that. The previous trials that have been conducted with the stem cells have not been successful so far. And so we do not have proof of that yet. But as further research occurs, we'll have probably a better idea who would be the candidates who might benefit from stem cell treatment, because that has been the hallmark of treatment in bone marrow cancers. The stem cell transplantation has been highly successful.
And so then going one step further, post a massive MI in patients with heart failure, they've talked about lots of different therapies and things like that. And, we're investigating that. We've done a lot of studies with stitch and this and that and the other, as far as VADs and other things for patients who are not transplant candidates and whatnot. How do you see that evolving? Do you think we can ever regrow heart tissue and instead of transplanting, basically infuse stem cells in and cause them to de-differentiate or redifferentiate into the relevant muscular, neurologic, or other tissue?
Right. I think at present the research is in the early stages, so we don't know yet what the outcome will be. But I think for now, unfortunately, we are stuck with the question in patients who have a very low ejection fraction, whether to put them on a heart mate or whether to use a treatment in the advanced heart failure clinics, which are usually supported by the university hospitals.
Got it. And so here's another interesting thing. And to be honest, the idea of preventing, an ounce of prevention is worth a pound of cure, is an age-old idea. It's only now that we're really trying to do that on a population. And honestly, in the US, it was one thing where you have far more physicians, far more beds, far more education. In a place like India, where the total GDP spent on healthcare is less than 4%, of which 2/3 of that is private, you have a very challenging time getting patients to understand what's going on. So one thing I was looking at was these new devices which wear on your wrist, watches and other things, which track heart rates and look at data. Is there a way to predict from that, certainly for arrhythmias you can, but I'm saying for the recovery times from maximal heart rate and VO2 maxes and things like that in exercise to how the patients perform, can you predict who will be at risk long term? Is there a way to work out that algorithm?
I think that is a promising field of research, and I think as time will show whether they are going to be useful or not. But I think my own hope is that they would turn out to be useful, because in countries with limited finances and limited capability of using the high-tech devices, it would be worthwhile having those simple devices which could predict about the acute MI. And also, of course, now the interest is focused on trying to get the patients to the hospital as quickly as possible based on the ST segments, and some of the watches show the ST segment elevation that enables the patient to make a decision that he has to rush to the hospital immediately. And I think that's going to cut back on the mortality rate and the incidence of heart failure and cardiogenic shock in some of these people who recover from the MI but are left with disability due to LV dysfunction.
This is a very important point, which I wanted to reinforce, that minutes are muscle. And this whole door to balloon time that we talk about is critical in preserving myocardial or heart tissue. Interestingly, in India, it's often a rickshaw to door, door to balloon, and finding a facility to take care of you. So here, I think the bigger focus initially has to be on awareness and training people to understand what the risk factors are, mitigating those risk factors, and then also giving them a heightened awareness of the symptoms and when they should come in. Because obviously, if you come in sooner, like you're saying, outcomes can be improved, and it has to be through low-cost, high-impact means. It cannot be through something so expensive. And I would say that's true globally, not just in India. I think this idea of moving the pendulum to prevention, early recognition, early treatment has to be the basis of what we do to increase longevity and lifestyle. But I think that sometimes the model of healthcare is so situated on acute care and treating something every time, they don't really address that. I mean, there's no financial reward in prevention many times, whereas in treatment there may be. That's a separate deal, which we won't get into. I think, what I can tell you is you have added so much to the practice of medicine globally as well as in Denver. And you're a living legend. And I would love to have you on the channel more. I would love to participate with you in teaching on the different panels we do and other things. And I'm looking forward to that now. Rather than you being in the trenches now, you're going to lead from above and develop armies of people who will, be helped by your tremendous teaching and by your tremendous humility and your tremendous ability to bring things forward. But I can guarantee you your patients and everyone else will miss you dearly.
It's been a pleasure serving the people for so many years, and I'm happy and very fulfilled in my life that this has happened. And I certainly thank friends like you who have done a great job in India and have been highly successful. And I wish you the best, and I thank you for inviting me for this meeting.
If you like what you're hearing, hit the like button. Want to share it with all your friends, that would be great. And hit the subscribe button if you want to see more episodes from this channel. Hit the bell icon so that you can be alerted to the next one that we come up with. Thank you for joining us as always. It's always been a pleasure, and I look forward to seeing you again.